Good morning. My name is Erin Moran, and I'm the Clinic Partnership Manager here at the MAVEN Project. Thank you all for joining us today for appropriate use of laboratory testing in the surgical patient with Dr. Robert Lohr.
Good morning, everyone, and welcome. I hope you all have your coffee with you. I do, and so we'll go ahead and get started. Thank you for the opportunity to spend a few minutes with you. These are the disclosure slides that Erin just referenced, and also the accreditation slide for 1 hour of credit. A couple of additional points to make. I'm not going to discuss any off-label use of drugs, but importantly, I'm going to be presenting this data and information from the perspective of a general internist, which is what I am, who spent many years staffing a preoperative evaluation clinic and on the wards doing perioperative consultations at an academic medical center. So I know that you are a primarily primary care audience, and I will try to keep this applicable to what you do in practice. Our objectives today are to define and apply the rationale for evidence-based preoperative testing in the context of high-value care, and importantly, to remember that this is for the average risk patient. We're going to be talking about higher risk patients and what other things need to be done a little bit, but you should approach your patients as average risk, or are they more? And we'll define when testing is indicated and when it is not necessary. We'll start with some background in terms of the nature of the problem. I then have a couple of cases to go through to demonstrate a few points, and then we'll spend some time discussing the rationale and the reason to do specific tests or not to do specific tests. And there should certainly be some time afterwards for some questions. Well, this is not a new problem, and this is too small for you to read. I understand that. But the point is, this appeared in JAMA in 1985, which is likely before many of you were born. I was born then, however. But even back then, in this study, it was a retrospective review, they found that 60% of the routinely ordered tests would not have been performed if testing would only have been done for recognized indications, and 0.22% revealed abnormalities that would really make some difference. So it was recognized a long time ago that we probably overtest when we are doing preoperative evaluations. It's still a problem. This is a study from 2021. And this was a study in Michigan, again, retrospective, but they found that half the patients received at least one needless preoperative test. They also found in the day now, the current situation of electronic medical records, that hospitals and clinics lack protocols to de-implement low-value testing. In other words, the protocol's there, we're going to do it, and it lasts for 100 years. So this is a big problem. If you take, for example, innocent, minor test of a urinalysis, we do pushing $5 million worth of urinalyses for preoperative testing that doesn't need to be done. And that's about the least expensive test that I could come up with. So you can know that it goes up from there. It exposes patients to needless blood work and procedures. It can create anxiety for patients if there's some abnormality or incidental abnormal finding that's found. It's still a problem, mostly in terms of who orders more. Surgeons order more than anesthesiologists, and anesthesiologists order more than preoperative clinic directors. And then importantly, and we'll touch on this again, it requires follow-up of sometimes meaningless abnormalities, but sometimes abnormalities that do need follow-up. And it's a question of making sure that things don't fall through the cracks, which can be a significant problem. Well, this study looked at the question of why do we overtest, at least from one aspect of it. And it's an interesting study, so I thought I would go through it briefly with you. A group of hospitalists were divided into 4 groups. They all had the same clinical scenario, which was an elective gallbladder operation, cholecystectomy, in a patient who has coronary artery disease, but a good functional capacity, which, as we'll talk about, is an extremely important aspect of the cardiac part of doing preoperative testing to assess that. So the group was divided into 4 sections. The group A had no information about the patient's son who accompanied the patient to this exam. Group B, the son was identified with a physician. Group C, the son was not identified as a physician, but he was asking for more testing. And group D, the son was identified as a physician and requesting more testing. Now, the vignette, the choices that these folks had was to do nothing, to do a cardiology consult, a stress test, a cardiac cath, or an echocardiogram. And the benchmark was the current American College of Cardiology, American Heart Association guidelines. And they would say in this situation that no testing from a cardiac standpoint was needed. So when the son was not identified as a physician and not requesting everything, or anything rather, there was still over half of the respondents ordered something. When the son was identified or not, but it was still requesting things, that went up to 57%. And if the son was identified and requesting, it went up to 65%. So of the respondents who overtested, 37% said they thought they were following the guidelines, which means that there's some educational opportunities here, and that's what we're doing today. 2/3 said they wanted to reassure the patient or the family and themselves. But if you look at the rationale for doing some of these things, you're not really reassuring yourself, and you don't need to, because the specific things that were offered really don't need to be done. Well, so why do we overtest? Is there a lack of awareness of the guidelines? Sometimes there is. The desire to reassure patients and family and yourself. There may be concern about medical liability, and that plays into this to some degree. And sometimes there's concern about negative feedback based on patient satisfaction surveys. All of our patients get these now. And if you're not ordering something that the patient or their family member thinks that they need, you can get dinged on that in a negative way. And we all have time limitations on how much time we can spend with our patients, and explaining why you don't have to do something and trying to reassure the patient in a manner that they understand and that they buy into takes some time, and we just don't have that much time. So the default is, okay, we'll do it anyway and order the test. Well, should we test? We do need to identify or verify conditions that could affect anesthetic care and the perioperative course. And you need to look at this visit with the patient as a consultation. Normally, you are the referring physician, but in this case, you are the consultant. And although you are almost always asked to, quote, clear the patient for surgery, it is not a clearance. The only person who ultimately decides this patient is going to the OR, or we're going to put them to sleep or not, is the anesthesiologist. It is not the surgeon, it's not you, and it's not the patient. So to say that you cleared them actually opens you up to some potential liability. If you say that they're cleared and something goes badly down the line, you could be liable. It's much better to say that you've evaluated the patient and their medical conditions and that they should be able to proceed with the planned procedure with the following recommendations. And then you can, they should have this, that, hold this medicine, give that medicine, and so forth and so on. But I would not use the word clearance. We should help formulate or even modify anesthetic care. We're not anesthesiologists, but there's information that we may have that will be helpful for the anesthesiologist to make some decisions in terms of how they will treat this patient. Now, when you are thinking of what do we need to identify and what do we need to mitigate, there are 6 areas that you need to think about for every patient. Their cardiac status, which really is the most significant aspect of a preoperative evaluation. And it's actually a separate talk, which I'm happy to do for you sometime if you want. But you do have to spend some time on their cardiac status. We'll talk about that a little bit more. The patient may have underlying pulmonary problems, and so you may have to mitigate some, or attempt to mitigate some issues there, make sure they're on their inhalers or whatever they're taking. Most of our patients are taking drugs, not street drugs, but prescription drugs. And they need to know what to take and what not to take the day of surgery and how that needs to be adjusted. After the surgery, that's going to be handled by the folks in the hospital, but beforehand, it's you. Many patients, as you know, are on anticoagulants now. And so that has to be managed. When should the anticoagulant be stopped? Should it be stopped? When should it be restarted? There may be bleeding, clotting, or if they're on warfarin, bridging issues to address. Many patients, of course, are diabetic, and we need to manage their diabetic meds the day of surgery. And again, post the day after surgery, and subsequently, that's going to be managed by the surgical team or a consulting team, but you are the one who's going to be giving them their instructions for the day of surgery. And then there are a couple of other conditions that you need to be aware of and can certainly affect perioperative morbidity and mortality, particularly decompensated liver disease or decompensated cirrhosis, decompensated renal disease, and decompensated endocrine disease other than diabetes. And this usually is hyperthyroidism or Addison's disease. So those are things that you need to think about and address and make recommendations for. But if you think about these 6 areas, you're going to cover the bases, I think, adequately. Well, how do you decide what to do? Your last case that didn't go so well, what you were told to do in training, evidence-based medicine, guidelines, which ones, and the ever-present hospital policies and order sets, some of which you receive from the requesting surgeon. They're not even part of your organization. And who develops these and who makes sure that they're up to date. So let's start with a couple of cases to illustrate some points. And then we're going to go back, excuse me, and discuss several different specific tests. So our first patient is a 43-year-old male for a preoperative medical evaluation, and he's going to have an inguinal hernia repair next week. So pretty minor procedure, low risk. This will likely be done with anesthetic, with a local anesthetic. His past history is notable only for obesity and an uncomplicated leg fracture, open reduction internal fixation of a fib fracture when he was a teenager. Never used tobacco, very little alcohol. He does construction work, so he can easily do 4 METs of activity. And this is the functional capacity threshold that you need to assess. 4 METs is going up a flight of stairs or walking up a hill at a mile or 2 an hour. If patients can do that much physical activity, even with a significant past history of heart disease, they should be able to withstand the insults that the anesthetic and the surgery is going to throw at them. If they can't do 4 METs, then it may require some additional cardiac testing. But this man certainly can. Pardon me, I'm going to have some more coffee here. His only medicine is a multivitamin, and the only thing on his exam that you note is he is a little overweight and he has a reducible inguinal hernia. So what would you order for this patient? A cardiogram and CBC, a cardiogram and creatinine, a CBC and creatinine, a CBC and an INR, or nothing. We don't have the opportunity for you to yell something out. You're all muted, but I will tell you that if you yelled out no tests, you would get this correct. This man needs no preoperative testing whatsoever. And we'll talk about that a little more. Case 2, and this may be a little more typical, more complex patient that you, I think, would see. This is a 78-year-old female you're seeing for a preoperative medical evaluation, and she's scheduled for a right total knee arthroplasty tomorrow. Her past history is noteworthy for hypertension, hyperlipidemia, obesity, DJD, and coronary artery disease, for which she received 2 drug-eluting stents 4 years ago, and she's done well from that standpoint since. She's had a hysterectomy and carpal tunnel repair in the past, but no complications. Her medicines include a lisinopril and hydrochlorothiazide combination, simvastatin, metoprolol, and aspirin. She's limited due to her knee and her activity, but in questioning, she is able to do 4 mets, or was at least within a few months, until her knee really got bad. There are ways to assess the physical activity more than just asking questions like, can you go up a flight of stairs? There's a Duke activity scoring index, which has about 10 or 12 questions, which the patient can answer. It's a little form you have them fill out, and that will give you a more objective assessment of their activity. But we're okay that she can do 4 mets, or recently has been able to. Her exam is pretty unremarkable. The systolic pressure is up just a little bit. Her BMI is elevated, and she has an effusion of the right knee. Heart and lung exams are normal. You have an ECG, which has some nonspecific changes from 3 months ago, and no other laboratory data available. So what would we do for this patient? Update her ECG and check her electrolytes and creatinine. Just check her electrolytes and creatinine, ECG, lights, creatinine, and an INR. Electrolytes, creatinine, ECG, and a dobutamine stress echo, or no testing. Well, those of you that are thinking electrolytes and creatinine only are correct. Third case, you're asked to see a 58-year-old male for a pre-op exam, and he's going to have a right total shoulder arthroplasty next week. Past medical history is significant for hepatitis C, but no known history of cirrhosis. He had an inguinal hernia repaired as a child without complication and has had no recent follow-up regarding his liver. He takes a multivitamin. He can do 4 mets, and his exam is normal except for the right shoulder. So what should we do for this gentleman? Cardiogram, electrolytes, creatinine, electrolytes, liver functions, and creatinine, liver functions, INR, and creatinine, INR and PTT, or nothing. Well, this man, the main issue here is his history of liver disease. And so the correct answer is liver functions and INR, which reflects the synthetic capacity of the liver, and a creatinine, which is, of course, not a liver test. But the total bilirubin, the INR, and the creatinine are the components that you need to feed into your telephone in MedCalc to create a MELD score for this man. And that's how you evaluate the postoperative risk for patients with liver disease. And we'll discuss that again a little bit in more detail later. In our last case, preoperative evaluation for a 23-year-old female who's a college basketball point guard, and she is going to have a repair of a torn left ACL, common injury for young women athletes. She reports herself to be in excellent health. She's playing basketball, so she certainly can do 4 mets. No prior surgery. She does say she has irregular menstrual periods that she feels are related to her level of physical activity and the stress of playing college basketball. She's taking no medicines, and her physical exam is normal except for her left knee. So what would you order for this young lady? A CBC, a cardiogram, coagulation studies, pregnancy testing, or nothing? And pregnancy testing is what this should be, what should be done. So routine preoperative testing should be dictated by the patient's clinical conditions or abnormal findings that you detect on history and exam. So it's important to take the history and do a thorough exam. Preoperative testing is not indicated unless there's a reason to perform the test and that it will result in some change in management or mitigate perioperative risk. So let's talk about a few of these tests. The preoperative ECG. Almost every order set that I've seen for preoperative exam and lab studies requires or requests an ECG. Sometimes there's an age cutoff. There really are no prospective randomized or clinically controlled trials regarding this. There are no good prospective outcome data. There's a lot of reviews, lots of complicated and conflicting consensus statements, It is true, however, though, that the main cardiovascular risk assessment tools often use the ECG to help risk stratify. So it's also true that as you get older, the ECG more commonly becomes abnormal, and that after the age of 75, 75% of people actually have an abnormal ECG in some way or another. And there's some evidence to suggest poorer outcomes, surgical outcomes, in patients who have abnormal ECGs. Now, the absolute risk reduction is only 0.5%, so it's not a great deal, but there appears to be some legitimacy to doing an ECG in an older patient. The 2014 ACC/AHA guidelines, and those are the most current ones, are 10 years old now, state that the preoperative ECG is reasonable. So they're hedging on this for patients with known coronary artery disease, significant arrhythmia, peripheral arterial disease, cerebrovascular disease, or other significant structural heart disease, except for those undergoing low-risk surgery. Low risk is dental procedures, dermatologic procedures, most outpatient procedures, and breast procedures, and endoscopic procedures as well. You could consider it, again, hedging for asymptomatic patients with known coronary disease, except for low-risk surgery, and it is not useful for asymptomatic patients undergoing low-risk surgery. So if the patient has CV signs or symptoms, I would certainly do an EKG. If someone comes in and says, well, I used to walk up the hill and now I have chest pressure, when I do it, you better do an ECG, and probably more than that. If there is stable cardiac disease, you can rely on an old ECG, and in our practice, we will go up to a year as long as the patient is clinically stable. If they haven't changed and you have an ECG that's within a year, you don't need to repeat it. And that's why we didn't need to do the ECG on the elderly lady who was going to have the knee replacement. She had one within 3 months, and she clinically was unchanged in that regard. You also should do an ECG if there are risk factors and it is either intermediate or high risk surgery. High risk would be vascular surgery of pretty much any kind. Intermediate surgery is most of what's in between the high and the low risk. It's the orthopedic, the urologic, the general surgical, abdominal procedures, pulmonary procedures, and so forth. The tool that is used to assess cardiac risk factors most commonly is the RCRI, which is Revised Cardiac Risk Index. This has been around since 1999, a long-standing tool. And there are others that are available now that are sometimes used, particularly that which is embedded in by the American College of Surgeons in their quality base, NISQIP it's called. In any event, the RCRI is very commonly used, and a patient who has one or more risk factors per the RCRI is considered at higher risk for MACE, or major adverse cardiac events, postoperatively. So the risk factors are known cardiac disease, stable or not, heart failure, diabetes treated with insulin, stroke, and a creatinine, pre-op creatinine greater than 2, which suggests the clearance is probably in the 30 or so range. A CAD equivalent, which usually is diabetes. It is noteworthy that the current Canadian guidelines don't suggest doing this sort of risk assessment, and they don't suggest doing any stress testing, even if the patient's having some symptoms. They suggest doing a BNP and then following the patient very carefully afterwards. Now, this is for patients over 64 or under 64 if they have symptomatic disease. So the ECG is often done, as I said, if there's a current one, even in a patient with clinical heart disease, then you don't need to do it. So low-risk surgery, low-risk patient, no. I put cataract surgery specifically on here because that is low-risk surgery. It's almost always done in elderly patients. And they frankly don't need any pre-op evaluation. It's done with local anesthetic. Anesthesiology will see the patient briefly beforehand. We don't do, with very rare exceptions, we don't do pre-op evals for cataract surgery at the Mayo Clinic. And you would consider an ECG for the low-risk patient, intermediate surgery, or if they have risk factors. How about coagulation studies? In general, this should be as indicated by the history and physical. So as I thought about this question, I thought, who are the patients that have the greatest risk for bleeding postoperatively? And it's neurosurgical patients, either from a craniotomy or from spine surgery. But if you look in the neurosurgery literature, they will actually tell you that the patient history was as predictive as lab testing for outcomes and had greater sensitivity. So if there's a known history of bleeding disorder, or there are previous bleeding complications, certainly if the patient's on anticoagulation, and particularly warfarin, you wouldn't necessarily need to test anything for a DOAC, or if the history and physical suggests bleeding or coagulation problems, but not routinely. And it is very common, particularly for ear, nose, and throat operations, some orthopedic operations, some neurosurgical operations, that you'll be asked to do coags, but indeed it ought to be dictated by your evaluation. What about the CBC? Well, again, if the history and physical suggests problems, then you should do something. So if there's a known cytopenia, recent chemotherapy, a history of bleeding, if the patient looks anemic, they have pallor, those things all happen, but rarely. The most common situation where you would, I think, want to do a CBC are the last two. If you anticipate a large surgical blood loss, it's important perhaps to know the hemoglobin level preoperatively. So, for example, you have an elderly patient who's going to have bilateral knees done at the same setting. There could be a fair amount of blood loss, and you may want to know what their hemoglobin is to start with. And the second one is the situation where even a mild anemia could be significant. So again, this is the patient with known coronary artery disease, maybe known severe COPD, where you really don't want the hemoglobin to drop much. Because they could become symptomatic from that, and you would want to know where you're starting. What about electrolytes and creatinine? You would want to do them for patients who are on diuretics, certainly patients with renal failure, patients on DIG. I think, and there's no guidelines about this, but I think that you ought to consider it, and I'm hedging now, for the majority of elderly patients, due to the likely exposure to medications cleared by the kidneys that they're going to receive. Now, as you all know, the creatinine and the GFR go down as we age. And it's nice to know where we stand again with it, because if you have a GFR under 30, you may not be able to do the routine things that you normally would do post-op, such as using low molecular weight heparin for DVT prophylaxis. So I think a creatinine is not a bad idea, and probably a good idea for most elderly patients. How about the chest X-ray? So this is the routine chest X-ray. Going to the OR, you have to have a chest X-ray. Well, there are a lot of abnormalities that are found on these, between 10 and 23% of incidentalomas. However, they rarely influence management of the patient to 0.1 to up to 3% of the time. Usually, they are predictable from the H&P. And then you have the question here again of who's going to follow this up. So let's say you do this chest X-ray and there's a 0.5 centimeter non-calcified nodule in the left lung. It does need some follow-up. This patient is not your patient, it's somebody else's. How are you going to communicate to somebody else, whoever that is? And you may not even know who it is. You may just got this patient from the surgeon. Who's going to follow up, and how do you communicate that, and how do you make sure things don't fall through the cracks? This is a big problem, and something that you need to think about if you uncover any sort of incidental abnormality. What about albumin? There's a lot of literature on this, and in some settings it can be a relatively powerful predictor, particularly for pulmonary complications, also infection, wound healing. And in some settings, again, pulmonary, it may be the strongest predictor of morbidity and mortality. The issue with the albumin is that it's extremely nonspecific. It may say, well, this patient's at higher risk, but you don't know why. And I have never drawn an albumin or requested an albumin specifically to assess risk. I have if the patient appears to be malnourished, or if I know they're malnourished because they haven't been able to eat for a long time, they're going to have some GI procedure and that sort of thing. So you could consider it if there's a modifiable risk factor present, like tube feeding before surgery or TPN before surgery. And again, it would change perioperative management, but otherwise, I don't think I would be doing routine albumins. Glucose in the non-diabetic patient. Well, there's no good evidence for or against. Would it change your management? I would hope that in your questioning of the patient, you would get some hint that they may or may not be diabetic if they don't know they are. If they're an obese patient with a strong family history of diabetes, they've been losing weight and they're urinating frequently, I would check a blood sugar. Otherwise, I'm not sure that it makes any big difference. Now, for the diabetic patient, we usually check a hemoglobin A1C and see where they are. And there are some procedures, particularly orthopedic procedures, that the surgeons really want to have the A1C under 8 in order to proceed, because there is greater likelihood of wound infection and wound healing issues. Liver function tests, and this goes back to our patient example. If there's a suspicion of liver disease on the basis of the history or exam, then you should order liver function tests. So our patient in the case that we discussed had a history of hepatitis C. If there are indications to perform it, you should do the INR, the bilirubin, and the creatinine. And as I said, those are the 3 elements that you need to feed into the MELD equation, which is used for 2 purposes. It's used to assess basically liver viability in preparation for liver transplant. That's how it was developed. But it's subsequently been studied and verified that it does predict perioperative morbidity and mortality. And the counts go up, the score goes up very quickly, and the morbidity and the mortality goes up very quickly. I personally find that patients with cirrhosis that is somewhat decompensated are the most difficult patients to take care of after a major operation. If they've had a history of GI bleeding, that often recurs. Their ascites gets worse, their encephalopathy gets worse, their platelet count goes down, their clotting is worse, their INR goes up, their blood pressure drops, their renal function deteriorates. You give them fluid and it all goes into their abdomen instead of into the vessels, and using more albumin instead. It's really a problem. So it is important to identify these patients and to make sure that you know where they stand. Now, a MELD score of 10 or less, usually, you can proceed. Shouldn't be any big issues. If it is over 15, the patient probably should not be having elective procedures and should be evaluated by a hepatologist or gastroenterologist, and actually consideration for putting on a transplant list. Between 10 and 15, I would probably get a consult from GI and see what they said about it. What about pregnancy testing? These are a couple of fairly old studies, but the data that they used is good, and the conclusions are, I think, good. Both of them are a couple thousand women of childbearing age having elective procedures done. And in both these studies, all of them had a pregnancy test done. Now, the rate of a positive pregnancy test was quite low, 0.3% and 0.2% in the 2 studies. The cost of doing that was somewhat high, but it went up in the more recent tests, but not exorbitant. But the women who found out they were pregnant and didn't know it ahead of time canceled their surgery. So it did change management. They didn't want to have the anesthetic risk. Is there an anesthetic risk? Well, our anesthesia colleagues say that the literature is inadequate to inform patients or physicians on whether anesthesia causes harmful effects during early pregnancy. Pregnancy testing may be offered to female patients for whom the result would change management. So again, they're hedging a little bit, but I think that it's probably a good idea to do the pregnancy test, because whether or not there is a risk or not to the mother and the child, there is the perception by the mother that there may be a risk, and you don't want to take any risks. Now, the British and their National Health Service have decided that they want consensual blanket testing of all menstruating women for pregnancy prior to surgical procedures. And they debated this, and they found out that they had more adolescents in Britain who were pregnant, and they didn't think that the information they were getting from the adolescents was reliable. I don't know that that's true or not, but if any of your parents, I'll make you or let you be the judge of that. They don't actually do the blanket testing, but they say that they should be doing it. And I think that we should be doing pregnancy testing. Now, what about COVID? And again, this is a little small and hard to read, so I'm going to walk you through it. During the pandemic, the height of the pandemic, everybody who had a procedure got COVID testing, symptomatic or not. And the reason was that if they did have COVID and they exposed the operating room team to COVID, that operating room team was taken out of commission for a week or 10 days until it was sorted out who got it and who didn't get it. So they tested everybody. Now, I think that has been relaxed in most hospitals, though there is still a fair amount of testing done. But if you have a patient, you're seeing a patient who has had COVID, when is it safe to operate? So on this table, and this is from JAMA in January of 2022, so about 2 years ago, we're looking on the left side at the time from COVID diagnosis, and on the right side, the risk of MACE, which is again, major adverse cardiac event, low and elevated risk patients. So in the asymptomatic or mild or moderate illness patient, if it is less than 7 weeks since they had their COVID diagnosis, you would delay surgery across the board. If it's over 7 weeks and they are low risk from a cardiac standpoint, you could proceed, and you could consider or think about proceeding in the elevated risk group. Now, if they have severe or had a severe or critical disease, if they're less than 7 weeks, you again would delay across the board. If they're more than 7 weeks, but with persistent symptoms, you would delay across the board. And if they're more than 7 weeks, but with resolution, low risk patients, you could go ahead. High risk patients, you could think about going ahead. Now, this has been looked at more recently. This is a study from last March. It's not even a year old yet. And based on the timing of COVID, this is from the UK, from 2018 to 2022. Now, the majority of patients were waiting the 7 weeks, but 3% or a little less than 3% of procedures were conducted in less than 7 weeks since the COVID infection. And after the availability of vaccines became wide, the mortality actually was only 1.1% of surgeries within 2 weeks of the COVID diagnosis and 0.3% if within 4 weeks. So what this suggests is that in the asymptomatic patient, if the surgery is urgent, in other words, a new cancer diagnosis, we'll say, something that you don't want to wait if you don't have to, you may be able to go earlier than 7 weeks. At least there's some information to suggest that. So the take-home points in general here are that, first of all, there shouldn't be, quote, routine pre-op testing. It all should be dictated by your history and exam and the patient's clinical status. Another point that I want to emphasize is that every patient that you see for pre-op evaluation should have testing for OSA. It's very, I know you know how to do it. There's multiple tools, stop, bang, and so forth. The reason for it is that untreated or unrecognized OSA does increase post-op morbidity and mortality. Post-operatively, you need to use continuous oximetry. You would consider moving the patient to the ICU for the first day or two, and consider moving an outpatient procedure to an inpatient setting, particularly if they're going to go home with the significant narcotic drugs for pain management. So have your nurse or clinical assistant do a quick assessment. It's a few questions, weighing the patient and measuring their neck circumference. Everybody has questions about meds. What do we do with the patient's meds pre-op? So we're going to go through a bunch of them here. Blood pressure medicines we generally give. with two potential exceptions. We usually hold diuretics the day of surgery because the patient's going to be MVO. They're just going to be getting IV fluid. There may be some significant fluid shifts, and we don't need to be, dehydrating them. So we usually hold diuretics. You would consider holding ACEs and ARBs depending on their baseline blood pressure. And the reason for this is that there is some reasonable evidence that suggests that patients on an ACE or an ARB will potentially drop their systolic pressure about 30 millimeters with the induction of a general anesthetic. So if you're seeing the patient for the pre-op exam and their baseline pressure is 150, 60 systolic, I don't think I would necessarily hold the ACE or ARB. But if they're really well controlled, 110, 120, I would. You do need to make sure that the antihypertensive drugs are reinstituted promptly post-op, because if you don't, the pressure is going to zoom way up. They're in pain and so forth, and the blood pressure will be a concern post-operatively. Other blood pressure medicines you can give. Diabetics, in general, you should hold their PO meds, particularly metformin should be held. You can give ultra-long-acting insulin. So Lantus can be given at full dose. Now, again, there's the caveat to this. Most of the time, Lantus is prescribed in the evening. And I always ask the patient, what is your first morning blood sugar before you have breakfast? And if they say, well, it's, 130, 40, 50, I would give the full dose of Lantus. As you know, it doesn't peak, it kind of goes to a plateau and stays at that level. Now, if they tell you that their first morning sugar is 90 or 100, I would probably cut the Lantus dose maybe by half. Because you don't want to have them start out hypoglycemic. Intermediate acting insulin, NPH, you should cut by 50% the day of surgery. Now, what about the newer drugs, the sodium glucose inhibitors? These drugs should be held 3 to 4 days pre-op. And the reason is that you can get a normoglycemic ketoacidosis with these drugs. So the patient goes to the OR, they're NPO, they're getting IV fluid, they're not eating. Glucose looks great, but they could be becoming ketotic, and you wouldn't necessarily know it unless you're checking for ketones, and that isn't routinely done. So they want these drugs out of the patient's system. So 3 to 4 days ahead, the flozins, as I call them, should be stopped. Now, what about the glucagon-like peptide receptor agonists, the TIDEs? They should be held the day of surgery, or if it's an injected form, the week of surgery. And the reason for this, as you know, these drugs cause a good deal of weight loss, which is a good thing most of the time. But they do that by slowing gastric emptying. And that can result and has resulted in increased risk or increased occurrence of aspiration when the patient goes under an anesthetic. So, you obviously want the patient's stomach empty. So you would hold the day of the surgery or the week of surgery if injected for the GLP-1 receptor agonists. Beta blockers and other cardiac meds, you can continue. Anticonvulsants, you certainly should continue. You don't want to have the patient wake up and have a seizure and then go to sleep again. Pain meds should be continued. And this includes buprenorphine. You need to, obviously, you'd be listing that as a med if the patient's taking it. The post-op people are going to need to increase their use of opioids to control the pain in these patients, but you can continue the buprenorphine. Parkinson meds should definitely be continued. Again, the patient's NPO, they're not eating post-op, and they are time to get them out of bed and move, and they can't. So continue the Parkinson meds. MAO inhibitors, you can give. We used to say you couldn't, but you can. And inhalers should all be continued. And I think the PRN inhalers, the PRN albuterol for somebody who may have exercise-induced asthma, I tell the patients to take the albuterol the morning of surgery, even if their breathing seems fine, because there is some element of bronchoconstriction that occurs with induction of anesthesia. So continue all the inhalers. These are a couple of good summary references. One's from 2020 and the other from 2022. But if you want to read more about this and have more detail, these are very, very well written and well referenced references. And that is all I have prepared. So we have, I think, some time for some questions here, and we'll have Aaron open things up. I'm going to stop sharing if I can get the stop sharing the screen. There we go.
Great. Thank you so much, Dr. Lohr. We actually already have a hand raised. I'm going to go ahead and unmute them.
Anna, go ahead.
Oh, thank you so much. That was just so amazing. So I have two questions. One of them is undiagnosed sleep apnea in obese patients. I know there have been cases where a patient was found dead on the floor from, post-surgical pain medication. And so whose job is it to make sure that, because most of our patients are obese now with larger neck circumference. So how do we, evaluate those patients? And so is this anesthesia, is it the primary care, or whoever the surgeon is doing it? And secondly, cataract surgery. We get, clearance requests from the eye surgeons. Can you go over on DOACs and also Coumadin?
Okay. We'll do the OSA question first. As I mentioned in the talk, you should be screening patients who don't have a known diagnosis of OSA and who you think are at risk for it. So, if a very thin person comes in and they don't snore a lot, I don't think I'd worry too much about it. But if the patient is heavier than they should be, and there's a history of snoring, I would do the usual assessment with the stop bang questionnaire, measuring the neck, weighing them. And if they have a high risk of OSA, you need to be very prominent in your note to mention that. And it's primarily for the anesthesiologist. You can try and call the anesthesiologist, but it's very hard to know who's going to actually be in the operating room with your specific patient. But if you note it there, this patient is high risk for OSA, you can say, please use continuous oximetry post-op. If it's an inpatient procedure and they normally would go to the floor, you might suggest that they be housed overnight, the first night or so in the ICU, so they can be watched more carefully. Our anesthesiologist actually will do some testing in the PAR, the post-anesthesia room, before they'll send the patient, either to the floor or to the ICU to be monitored, to see if the patient is awake enough and tolerating the pain meds and so forth. But you're correct. If somebody has severe OSA, they have had a major operation, they're getting a lot of opioids to control the pain, they may just stop breathing and we have a respiratory arrest, which you don't want to have. So the main thing is to do the screening and to note it prominently in your note with recommendations. And then it really is up to the anesthesiologist to deal with. Now, the second question, I missed part of it. It's regarding cataracts and DOACs or anticoagulants. Is that correct?
Anticoagulants, yeah, DOACs and Coumadin.
Okay.
We are always asked to clear patients.
Yeah. A cataract procedure is a bloodless procedure, and the ophthalmologist, will say, well, I don't want the patient on an anticoagulant, but there's nothing in the literature that suggests that there is increased danger of doing that. So the patients really do not need to come off any anticoagulant. That includes aspirin, clopidogrel, DOACs, warfarin, any of that. They can just stay on it. Now, if the surgeon says, I won't do it, then obviously you're going to have to take them off. They almost all will do it with a baby aspirin, but they may or may not want to do it with the actual anticoagulants. So warfarin, if they're on warfarin and the surgeon says they will not proceed if you don't take the patient off, warfarin should be stopped 5 days ahead. You have to ask why the patient is on the warfarin to determine if they're really at high risk for thrombosis, if they're off warfarin or not. Because if they are at really high risk, and this is usually a patient with a prior stroke due to an embolic phenomenon, then you'd have to consider bridging them with low molecular weight heparin. So you'd stop the warfarin 5 days ahead. 2 days ahead of surgery, you'd start some low molecular weight heparin, stop the day before surgery, and then restart the heparin a couple of days after. And it's fairly complicated to do. We don't bridge much anymore, but in the really high-risk patients, you should consider doing that. If they are on a DOAC, you have to know what their renal function is. And if they are on a dabigatran, which is a thrombin inhibitor, that usually has to be stopped several days ahead of time, particularly if the GFR is under 50, actually. The apixaban, Eliquis, rivaroxaban, Xarelto generally are 1 to 2 days ahead, depending again on their renal function. So the short answer is you don't have to stop any of them for a cataract, but if the surgeon insists on it, you'd have to, make recommendations as if the patient was having a bigger operation where you would have to stop an anticoagulant. Does that address your question?
Yeah. Yes. Thank you.
Okay.
Thank you so much, Dr. Lohr. And we do have another raised hand.
Gloria.
Hi, good morning. I have
Hi.
a question. If your patient has diagnosed, let's say, severe obstructive sleep apnea, and they're going for surgery, like an outpatient procedure, do you recommend that they take their machine with them so it could be used post-operatively?
Yes, I do. We do that routinely. If they have known OSA, we say bring your CPAP machine or whatever they're using to the hospital, and respiratory therapy usually sees them and makes sure it's all working correctly and so forth. But they just use their own machine, and that works.
Yeah.
That works quite
Perfect.
well.
Thank you.
Mm-hmm.
All right, any other questions? Please feel free to raise your hand, or you can submit them into the Q&A box or into the chat. Anything else? We still have 8 minutes, so feel free to put any questions in that you may have. Oh, and we do have one. Any special considerations for cosmetic surgeries?
Any special what recommendations?
Considerations.
For what type of cosmetic surgery are we talking about here? Right, you can unmute them if you want.
Sure. We'll give her an opportunity to type it into the chat. Oh, here we go.
So this is Whitney. Go ahead.
We see a lot of patients coming to our urgent care who don't have primary care providers getting foreign plastic surgery. A lot of things like Brazilian butt lift, breast augmentation. And generally the patients are, young and healthy, but we're asked to evaluate them preoperatively since they don't have primary care. So are there any special risks to consider in those types of surgeries?
No, I don't think there's any special risk. If it's a breast augmentation or something like that, that's breast surgery is considered low risk, but it probably would be with general anesthetic. So you have to go through the usual questions that you would normally ask for anybody going through a general anesthetic. If it's a local anesthetic sort of thing, you probably don't need to be doing it pre-op, frankly. But if they are going to have a general anesthetic, they should have is their functional capacity good? Make sure that they know what to do with their meds. They haven't been on steroids recently, no alcohol consumption, significant alcohol consumption, those sorts of things need to be asked. Have they had prior complications, particularly bleeding complications with the plastic surgery procedures? But otherwise, they wouldn't be at any particularly higher risk than anybody else. And as you say, they're usually younger, healthy people, so there likely wouldn't be any problems.
Morning. Happy New Year.
So, I'm sorry, Dr. Lohr, I have one question. Maybe this is for Erin. So I'm an internist, an infectious disease, and I've always seen different, from my fellow, providers, different screening tests, what is appropriate for a brand new patient, age-based, what are appropriate, screening blood work, and also yearly blood work. What are the risks? And is there any way that you could give a talk at some point? Because we are in the value-based payment system, and these lab tests cost a lot of money. And so just a little bit of guide. I don't see any particular guidelines. I'm an internist. I'm used to doing, CBC, CMP, and, my 60-year-old people. But then I see other, 60-year-old persons that don't have anything else except for infectious disease screening, no CBC, no CMP. And so I think that it would be great to go over what are the initial age-based screening blood work and the yearly physical and things like that.
I think that'd be a good topic. I agree with you. I'm not going to cover it all today. The rule of thumb still should be similar to what we have talked about today, that if the patient, aside from their age, has underlying diabetes, underlying heart disease, and so forth, that should inform what you should be doing. So the diabetic patient, you're obviously going to be following their blood sugar and their lipids, and that sort of thing. The patient without diabetes who just happens to be 75 years old, probably their lipids, if it's a male, you would consider a PSA, although that gets cut off at about 75 usually, or decreased in frequency. I'd have to go back and look at some of the recommendations, but there may be something, I could look it up, but the Annals of Internal Medicine has a column every issue called In the Clinic, and some are outpatient topics, some are inpatient, but you might look there on their website. It's acponline.org, and see if they have anything on just routine annual blood testing and so forth. And they would provide for you a pretty minimalist approach. The other resource would be the USPSTF, the United States Preventive Service Task Force website, and see what they say about it as well. You're correct, though. You're a subspecialist. You're getting patients referred, and they say, well, you're an internist too. So, bring the patient up to date on this, that, and the other thing. And it's hard to know exactly what to do, or what you may not need to do. But I think those two resources would be helpful, and I do think it would be a good topic too.
Yeah, and then just to interject, Dr. Haptu, maybe offline we can talk with Kristen and Nick about maybe scheduling a group consult to focus on this. So I'll reach out to our program manager, Kristen, to hopefully facilitate this for you guys. Are there any other? Oh, go ahead.
So I say thank you.
Oh, okay, great. So any other questions? We still have 2 minutes. All right, if not, well, thank you so much, Dr. Lohr, for your time today. And then just a reminder for everyone, when you're filling out the CME survey, please do use your work email addresses or whatever email you registered for this session for. And again, thank you so much, Dr. Lohr, for signing on early and doing this talk for us.
Thank you very much, and thank you all for your time this morning. I hope that this was useful for you.
Have a great day, everybody.
Bye-bye.